born and raised in New York City, and I was publicly educated there, lived there through medical school, then went on to the University of Michigan where I did a residency in internal medicine. After that, thought it would be nice to live in a rural setting for a while, so I volunteered to work in an underserved area in upstate New York as part of the National Health Service Corps as a primary care physician. Had a great time there. After that, went on to join the faculty at the University of Vermont in Burlington, now called Fletcher Allen Healthcare, where I was in the section of general internal medicine, teaching students and residents, and mostly practicing medicine. During that time, my interest was largely in the area of doctor-patient communication and teach interview skills to students and to residents using videotape to help them learn their skills. After that, I was recruited to the Cleveland Clinic to be the leader of their newly constructed Family Health and Surgery Center out in the suburbs of Cleveland, which was a facility that had about 40 doctors, multi-specialty group with operating rooms, pharmacy, physical therapy, imaging, and sort of brought that from the ground up and developed it and hired everyone into that facility, and that did very well. While I was there, I was also an associate program director for the internal medicine residency program at the Cleveland Clinic, so I learned a little more about the academic side of managing a training program. After about 7 years in Cleveland, I was asked to go down to Florida, where the Cleveland Clinic ran a large group and a hospital campus outside Fort Lauderdale, to be the director of that. I was there for 3 years in that capacity, and then went to the Carilion Clinic in Roanoke, Virginia, which is where I was for 5 years before starting this job. And that intrigued me because the stated goal of that organization was to transform itself from a hospital system which happened to employ doctors to a physician-led multi-specialty group that happened to own hospitals. They recognized the importance of putting physicians in positions of leadership to try to begin to create an organization that had integrated care. And so for 5 years I was involved in the senior leadership there to make that happen. The position I came to now, here, really was one that was very consonant with the work I've done in the last 5 years. And I was attracted to this job because a lot of the things I had been doing were very much in line with, I think, the way healthcare is going nationally. And I was intrigued by the idea of coming here and sort of, again, being involved in helping the organization move in that direction. But this organization, in my interview process, very clearly stated that they understood for us to be as successful in a world of pay for value as it has been in a world of pay for volume, that the physician group has to be strengthened and has to really help lead the way to that transformation of care. And that is exactly the work that I'm comfortable doing and feel strongly about and passionately about should happen more nationally. The governance summit that I attended when I came here confirmed that that was indeed what the leadership felt. And so my feeling is we're going to do this in stages to bring that to fruition and create an integrated health system. I think the first step of that is to provide the basic legitimate needs of physicians to allow them to do their work. We need to provide them with a fair market-based comp plan that is administered well. We have to give them the tools to do the work, which is an updated state-of-the-art medical record. We have to provide them with an environment and staffing so they can work productively in their offices. And at some point, we should plan things beyond that where we can have centralized services such as a after-hours nurse on-call answering system that allows us to triage and care for patients 24/7, allow them to schedule patients into a central scheduling system, and other things that make physicians more effective and increase their professional satisfaction. And once that groundwork is laid, we need to begin to take a population approach to care. We have to begin creating a system where we can respond to the marketplace, which I believe strongly is going to go from organizations and employers providing a benefit to patients, but to go to giving them a contribution for their care. So I think large organizations are increasingly going to say, here's your check, here's what we're going to contribute to your health care, now you go ahead and find health care out in the marketplace and find insurance that you want to pick. And I think for us to be competitive in that marketplace, we have to be the go-to place. We have to be the place where people say, I heard Peace Health gives you great quality, great patient service, as at a reasonable cost. And we have to put in place the things that allow us to do that. So that would start with a very strong functional basis of a medical home, where we have a population approach looking at a large group of patients that have decided that we're their primary care source, and think about them in their care, whether or not they're in front of us in the office, but even at home and in other parts of the system. So we have to focus on preventive care, management of chronic medical problems, increasing access so people don't overutilize the high-cost parts of the system that we're going to be responsible for financially, then really putting intensive work into managing the sickest of the sick folks so we can keep them out of the hospital and have their care be successfully managed. And in doing that, we also need to have our primary care doctors and specialists begin to talk to each other about how to care for patients that they mutually are responsible for. So, you know, what is the primary care's role in treating heart failure or diabetes or COPD? What's the point of threshold of referral, and what workup should be done so that we make the most efficient use of the referral visit so patients' time isn't wasted and the specialists are working to the top of their license, and as we all are, and providing the care that's most appropriate given the stage of illness that the patient's in. I think a lot of what we're doing is be working that value equation. We'll be talking about how do we set ourselves a high quality bar and learn how to get there? How do we give patients the absolute best experience they can have? And how do we do it at lower cost? Not just lower cost to us, but lower cost to the patient, because they're going to be very sensitive to that when more of their money is going into their care, which I believe will happen. So we're on the threshold of a fairly major transformation, and I'm very aware that change is not easy, and it will take a lot of our effort to work together and collaborate to do this. But from everybody I've met so far on the tour that I've been doing, I think this is a great substrate from which to do this, and I'm actually very excited to be here and do this work with all of our folks.